Is there anyone? Hello?
Hello?
Hello, yes, sir.
Hi. Hello, good evening, sir. How are you?
I'm fine. How are you?
Oh, very fine, sir. How is it? Is this Sunday you are enjoying?
Well, I'm on call actually
Uh-huh.
in the hospital,
Okay.
and I just managed to get some a window that I have nothing to do at the moment. How are you?
Oh, very fine. Enjoying my life and kind of things. And
Yeah,
in this COVID period, it's very stressful also.
yeah. You're in India, right?
Yeah.
Yeah. How are you holding up with the COVID over there? Because I hear some alarming things.
I mean, from this side, actually, COVID patients are rising, but
Yeah,
we are taking utmost precautions, and cancer patient we cannot leave, and we are following a particular protocol as per our hospital guidelines,
yeah,
and things we are managing in a better way.
yeah. Well, we had the same thing a couple of months ago, obviously.
Uh-huh.
Especially around
Yeah,
February, it
actually,
was kind of.
as a participant, this is what I can see. Okay.
I hear
Okay,
someone
now can
in
you
the
show me
background.
your screen?
uh, just a minute, sir. I have to fix up all those things. Can I take a break from you, sir?
Yeah, sure, no
uh,
problem.
Thank you.
Okay, Dr. Derek has joined, no?
Two members got joined. Now he left. One person, Sunil Agarwal left.
Your mic is on, I guess. Can you hold the cam the other way? I'm seeing the screen upside down. Now it's correct. Yeah, unmute. Check mute.
So, Mr. Sentinel, hello. Can I audible? Am I audible? Hello.
I can hear you.
Yeah. So where are my slides? It is with you.
Oh.
No. I'm not talking to you, sir. I'm
Sorry.
talking to the coordinator. There is a third one who is a coordinator who is having everything. I myself, like Dr. Sunil Agarwal, surgical oncology head in eastern part of India, and where we do have a university training programs. Yes, sir.
Is there a button we need to press for the slides? I see on the right side slides with a red dot.
The dot.
It says slides. If I press that, shall I do it?
Yeah, they have to tell me where to start. It's already time.
Oh. So where are the slides?
So, you have got your slides over there?
No, I don't. Because I uploaded them yesterday and I did a quick run.
Yes.
There was a way to share, maybe. What was that? I did that yesterday. How do I do that? Files, is that the one? Add a new file. I'm not sure if that's the way that it should be. Let's see.
Hello, Dr. Detrick.
Yes.
They said they have got the slide, and probably after this one, when they start the introduction, they will be sharing your slide first, and then it will be my turn.
Okay, lovely.
And unfortunately, Professor Human met an accident, I think so.
Yeah, I spoke with him yesterday.
And
he is quite okay though, but he was hit by a van. What I understood from it, on a bike, so he's all stitched up at the moment.
And Dr. Thomas also met in some COVID situation, some arises at their place, so probably he is also not joining. So we too will be there.
Okay. So we need to extend the
Good evening, sir.
Yeah, good evening. Good evening.
Good evening.
Yeah, hearty welcome Sunil Agarwal, sir, and Dedrick, sir, for your valuable presence here. And good evening, all. Welcome to the webinar on surgical techniques on women cancer organized by International Association of Oncology and Bioleagues worldwide. Yes.
Thank you.
We'll start the session. Considering the current scenario in society and the increased rate of cancer in women, we have organized this awareness webinar to discuss the surgical techniques in women's cancer. To enlighten us here, we have been joined today evening by some of the renowned oncologists in the medical science. First, I would like to welcome our expert speakers, Professor Dr. Human Sulaimani Masjid. He's a consultant gynecological oncology surgeon from Oxford University, NHS Foundations Trust, Oxford, United Kingdom. And Dr. Sunil Agarwal said, hearty welcome to you, sir. He's a professor and head at Department of Surgical Oncology at IMS SUN Hospital, Bhubaneswar, Odisha, India. Dr. Thomas Varghese as a Director of Cancer Division and Senior Consultant and Head at Department of Surgical Oncology and Reconstructive Surgery at Renai Medicity Hospital, Pallavatum at Cochin CM Hospital, Pandalam, Kerala. And Dr. Deidrick Dejong is a consultant gynecology oncology and clinical lead ovarian cancer surgery at St. James University Hospital, senior university lecturer at University of Leeds, United Kingdom. Hearty welcome to both of you to be present here, and thank you all for us joining today. So before we begin, I would like to introduce you to the organizers of this webinar, the International Association of Oncology. And prior to going to that, I would like to give a brief explanation about International Association of Oncology. Is one of the world's leading professional association for medical oncology and life science professionals caring for people. IAO is a non-profitable professional association meant for research and development in the field of medical oncology and life science. IOA is an international forum for researchers, academicians, doctors, and practitioners for sharing knowledge and innovation in the field of healthcare and life sciences. IAO aims to bring together worldwide researchers and professionals, encourage intellectual development, and provide opportunities for networking and collaboration. IAO meets with its objectives through academic networking, meetings, conferences, projects, research publications, academic awards, and scholarships. IAO strives to enrich itself from its diverse group of advisory members. So IAO brings together medical oncologists, life scientists, medical practitioners, and researchers to advance the application of medical oncology to the public. IAO delivers access to its members the industry's most essential technical information by organizing conferences, workshops, annual conventional meetings, and provides networking opportunities both locally and globally. Members have the ability to stay current in their chosen profession, connect with peers, and invest in their future. So this is our, as you can see in our slide, so this is our upcoming conference, which is Asia's Pacific Cancer Congress, going to conduct on 6th and 7th December 2021 at Maldives. I request everyone to be a participant and make this conference well successful. And before going to this, I would like to give a small introduction about Bioleagues, the other organizer Bioleagues. I request you to be patient so that we will go with a video.
Welcome to Bioleagues Worldwide, prominently promotes research and development and have brought a revolution in the field of worldwide conferences. In this video, we want you to dive into our world.
more inside.
I'm sorry, sir. It's due to network. It's still buffering. I request everyone to be patient while we play this video.
Giving yourself a clear insight of the Bioleague events. But first, who are we, and what do we do? Bioleagues Worldwide, BLW for short, is one of the world's largest non-profitable professional associations operating under the Techno-Read Research and Development Association, DRADA, meant for research and development in the field of engineering, science and technology.
Yeah, I'm getting your audio.
Conferences bring together
voice.
professional wizards and leader bodies for scientific professionals in India and across the globe, established in 2000. We extend to every part of the globe, with more than 28,000 professional members and 34,000 student members. Our founding membership at Bioleagues has led to an increase in members from Europe, Asia, Australia, and Africa, fostering networking opportunities that strengthen ties. Worldwide, prominently promotes research and development and have brought a revolution in the field of worldwide conferences. In this video, we want you to dive into our world, giving yourself a clear insight of the Bioleague events.
Yeah,
But first,
welcome in the
who
digital
are
world.
we, and what do we do? Bioleagues Worldwide, BLW for short, is one of the world's largest non-profitable professional associations operating under the Techno-Read Research and Development Association, DRADA, meant for research and development in the field of engineering, science and technology. Bioleagues Worldwide conferences bring together the professional wizards and leader bodies for scientific professionals in India and across the globe, established in 2000. We extend to every part of the globe, with more than 28,000 professional members and 34,000 student members. Our founding membership at Bioleagues has led to an increase in members from Europe, Asia, Australia, and Africa, fostering networking opportunities that strengthen ties within and across countries and technical communities. Bioleagues works with the motto of creating a better tomorrow by organizing conferences and creating a network which will help grow a better tomorrow with the help of advanced technology and achieve sustainable development.
If it is
Mission:
not working,
to
you can
connect
tell, if
professionals
you
at
wish,
an
you can
integrated
tell
platform for
about
growth to
Bioleagues.
divert knowledge through our professional activities and scientific conferences.
We are into the
Vision
machine
of a united
and
platform to
we work
explore
with the
research
same
with
motto of
opportunity to
creating a better
innovate
tomorrow.
multidisciplinary scopes and applications of professional
So,
studies.
this is the vision
Bioleagues
is coming
widely
to.
connects researchers, exchange global innovation,
we
and acts as a
we
bridge
will connect
between
with
other
more of
academicians
people
by
and we will connect
organizing
with divert,
international
we will divert the
conferences,
knowledge
world
towards all
conferences,
the
faculty development
countries.
programs, webinars, seminars,
This is about the
providing
vision.
membership, and more. Some of our conferences include Breast Cancer Dubai, 7th World
Yes.
Conference on Pharmaceutical
Bioleagues
Science and
widely,
Drug
worldwidely,
Manufacturing,
we are into the connecting so many
Nanosphere
researchers.
UAE, EduMIS,
We are into the global
Indo-Oncology Summit,
innovations,
International
and we
Conference
will
on
organize
Dermatology
multiple
and
services, all
Cosmetology,
the
and many
international
more.
conferences,
Every
worldwide
organized
conferences,
scientific events and
faculty development
association with
programs,
renowned
webinars,
universities
seminars,
done
and
in the
more.
past, with over
So,
28,593
few
journal
of our
publication
conferences, which
services,
include
creating
prominently,
opportunities
are
to get
the
your
breast
research
cancer,
paper published in
7th,
high-impact
the
factor
next 7th
journals such
Worldwide
as
Conference
Scopus
on
Index,
Pharmaceutical
Web
Science
of
and Drug
Science,
Manufacturing,
Google Scholar Indexed Journals,
Nanosphere,
SCI,
EduMIS,
and many more.
Indo-Oncology
To make
Summit,
our operations
international
smoother
conferences
and
on
more perfect, we
dermatology and
have been
cosmetology, and
supported
many
by our
more. So, few of
associated
our
organization,
worldwide
International
conferences.
Association of Oncology, IO,
And
Universal
we have
Society of
organized
Food and Nutrition,
scientific
USFN,
events
International Association of
which
Neuroscience,
are more
IAN,
than 28,000
International
plus.
Society of Environmental Relationship and Sustainability, ISERS,
Okay.
Association of
Okay.
Pharmaceutical Research, APR,
Yes,
Society
we are
for
mainly
Research
into the
and Studies of
Scopus
Nanotechnology,
Index journals and
SRSN,
Web of
and
Science.
many other
As you all
research
know, we were here
associations.
into the Google
Actively
Scholar Index
upcoming,
journals.
Association of International Society of Environmental Relationship
Yes,
and
to
Sustainability,
make our
ISERS, release
operations
upcoming
and
conference
development more
Climate
smoother,
Change Malaysia.
we are into,
We at
by our
Bioleagues
association, we
believe
are into
that
the
there's
IAO,
always a
which
better
is
way to
Indian
treat
Association of
professionals,
Oncology,
and that is what we
USFN,
do.
and
If you
neuroscience
would
as
like
well.
to explore with Bioleagues, visit our homepage www.bioleagues.com.
So these are the
Have
next
biology paid your way?
ISPRS and APR, which is Association of Pharmaceutical Research. So if
We are
you
not able
want,
to see your slides. We are not able to
sorry,
see
sir,
your slides.
it's
Probably you are,
completed. So whatever the
okay. Okay. So
whatever the Bioleagues introduction that I have to give in, that's completed. So we will proceed with the next part, which is I thank all our dear doctors for imparting your knowledge and expertise with us. So I would like to welcome Dr. Sunil Agarwal sir to speak a few words to our listeners who have joined us this evening.
so thank
Good
you.
evening, sir. Would you like me to present or your presentations? Should I?
I hope Dr. Dedrick should present. He's a guest of ours, so he should be given a first chance for presentation.
Definitely, sir.
Okay,
As you
thank you
wish.
very much.
So, good afternoon, everyone. Thank you very much for joining on this platform. I appreciate your appetite for knowledge and gaining the surgical skills so that you can deliver it to your patient and giving it to the best. In this COVID period, I do feel like positive vibrates are there. We cannot go to Leeds and learn from Dr. Dedrick about the surgical tips. But yes, Dr. Dedrick is here with his presentation so that we can learn a lot about from him regarding ovarian cancer. So before moving to Dr. Dedrick, I must thanks to the organizer who on this platform, this International Association of Oncology, along with Bioleagues, they have organized such a beautiful one, and such a large number of participants has participated, including a lot of surgical residents and surgical oncology residents across India, and I do feel like from many more countries. I cannot see which countries from which they have, but definitely from UK, and they have been informed me from other Asian countries like Philippines, Maldives. They have also roped into that one, and I do hope like this time which they are spending on this webinar will be a useful one, and this will continue. So with this, I must welcome our guest, Professor Dr. Dedrick De Rong. He is a consultant gynecological oncology and clinical lead ovarian cancer surgery at St. James University Hospital, LTHT. He is a senior university lecturer at University of Leeds at United Kingdom. Is an Dr. De Dong. He's an enthusiastic and ambitious consultant gynec-oncology, trained at Toronto and Rotterdam, holding full GMC specialist registration with a license to practice. Following his CCT in gynec-oncology, he had the privilege to gain experience with a wide range of surgical procedure. His foremost primary interest is surgical cytoreduction in ovarian cancer. In his current role as the clinical lead of ovarian cancer surgery, he has achieved the Center of Excellence accreditation by ESGO for advanced ovarian surgery at St. James University Hospital. St. James University Hospital and is one of the 15 centers in the whole of the Europe. It is in his role and clinical director at Rotterdam. He had the pleasure to work together with other specialists and management, resulting in implementation of surgical training program and introduction of Da Vinci robotics in gynecological oncology. There are many more accreditation is there. To cut short the time, let us welcome Dr. Dedrick De Jong with his presentation. And I must say to all the participants that they can put their questions on the chat and maybe after each session, the organizer will coordinate between the participant and the presenter regarding the question answer session. So after each session, they will be asking some questions. Is it okay? So Dr. Dedrick, all of yours.
Okay, thank you very much for your introduction, and thank you very much for inviting me. I've got no disclosures, and my talk of today is actually on radical surgery in advanced ovarian cancer. But I don't see my slides. Are they ever somewhere?
On the right-hand side.
Oh, I see it here. Fantastic. Yes. Start. There we go. All right. Thank you for the introduction. I have not much to add to it. I'm working currently in Leeds, St. James University Hospital in the United Kingdom, and since 2019 we are a Center of Excellence in Advanced Ovarian Cancer Surgery. My talk today is about radical surgery in ovarian cancer, and one of the subjects is how did we get there? How did we start performing surgery in advanced ovarian cancer? Well, first, a brief oversight. The FIGO classification is well known, I guess, by everyone. Basically, it means that there is disease outside the ovary or other origin organs. We're focusing on FIGO stage 3 and FIGO stage 4. Some people regard FIGO stage 2B as an advanced stage, but surgically that is not the real challenge. Today's ovarian cancer is quite diverse. Is quite diverse in terms of cell types. We've got the epithelial ovarian cancer, which is the overwhelming majority in ovarian cancer, of the ovarian cancers. Sex cord stroma tumors, I'm not going into that today. The role of surgery in that, and the same is for germ cell tumors. Epithelial ovarian cancer also has a grading system from well known are the Silverberg criteria for grading, grade 1, 2, and 3. But nowadays we're using the 2 tiers, dividing the low grades and the high grades. Important to know is that ovarian cancer is not only ovarian cancer per se, but it also includes fallopian tube cancer and primary peritoneal cancer. Advanced ovarian cancer currently today is a combination, the primary treatment of chemotherapy and surgery. Most recently, after the discovery of platinum, it is combined with other agents such as paclitaxel, and in the past, Dr. Rubinson. The administration is mainly by intravenous administration, but in 2006 there was a very important paper of Armstrong that started with intraperitoneal chemotherapy, and more recently from Amsterdam there was an important paper on HIPAC, that's heated intraperitoneal chemotherapy. The most important thing about it is that to make those and also intravenous administration of chemotherapy effective, it is that we must strive for a minimal residual tumor after the surgery. So, advanced ovarian cancer surgery, how did we get there? The first publication I could find, it was from a person called Sentinel in 1968. That's my date of birth, actually. And he was the first one who recognized the importance of surgery in advanced ovarian cancer. Back then, chemotherapy was actually not existing, and it was only surgery, sometimes in combination with radiotherapy. Of notice that he mentioned the word maximal surgical effort. In fairness, that was only a hysterectomy with bilateral salpingo oophorectomy and an omentectomy. In 1975, there was the publication of Griffin. That's quite a landmark article, and it was on surgery and chemotherapy. And he recognized the importance of residual tumor after surgery, although he did not specify what the aim of the surgeons would be. That surgery is important in the combination with chemotherapy is demonstrated very nicely by Maria Vandenberg. In this study, the patients were recruited from the open and close procedure in the general setting. Those patients were randomized to either chemotherapy or chemotherapy with surgery. And she showed basically that there was a survival advantage in the addition of surgery to the chemotherapy, and that was quite substantial. It's published in the New England Journal. That's all fine, but what is it? What is it what we are trying to achieve as surgeons? Empirically, the GOG in the US had defined optimal cytoreduction as less than 3 centimeters, and later on, that's another landmark publication of Hoskins. Hoskins showed that with less than 2 centimeter residual tumor, the survival, and that is the solid line on top, showing a marked improve in survival compared to more residual disease. Then there was the meta-analysis of Robert Briscoe in California in JC Journal of Clinical Oncology in 2002. And he demonstrated in his study quite clearly that less than 1 centimeter of residual tumor should be the benchmark for surgical cytoreduction. And that has been there a standard for a couple of decades. However, this result, and he also published that in that same article, the result of less than 1 centimeter is quite variable. From one practice to the other, it varies from 15% to 85% cases in total. So people are thinking like, okay, how can we improve that that goal of how can we get more women to less less residual tumor? One of the options was neoadjuvant chemotherapy, and that has been published by FIGO in 2010. That's a randomized controlled trial, as well as by Sean Keogh in 2015. And they demonstrated actually in their study that there was a non-inferiority of neoadjuvant chemotherapy followed by surgery in comparison to surgery first. I must say, quite disappointingly, the optimal surgical cytoreduction rate in the studies were like 41 and 73%. It showed basically that the neoadjuvant chemotherapy may improve the optimal surgical cytoreduction rate. So that was a good thing. However, last year's study in the real world, neoadjuvant chemotherapy, showed something different. This is data, this is the sheer data. It's a lot of women, I think about 30,000, no, it's not true, probably 20,000 patients were in that analysis. And it showed that if you do surgery first, that's the black line, it shows that there is the best or superior survival. Whereas if there is less than a centimeter residual tumor, when you do surgery up front first. That is the dashed black line. It is a little bit less, but still quite acceptable compared to previous data. The interesting thing is that after neoadjuvant chemotherapy, which is the red line, so they give first 3 cycles of chemotherapy, then do the surgery, and then have no residual tumor, that actually did not compensate totally to it. Actually, the survival was exactly the same as those who had less than 1 centimeter in the upfront setting. So it was actually quite disappointing. In the meanwhile, there was a very important study of Andreas Dubois from Essen, Germany. He did a meta-analysis, and he showed actually that the standard should be no residual tumor instead of less than 1 centimeter. So we're looking for other options than neoadjuvant chemotherapy. And the group of the Memorial in New York had a very nice study on that. In their study, they recognized that the complete or the number of surgical cytoreductions that did not achieve that was quite large. So that group the surgical group went into training, and they learned upper abdominal surgery with the hepatobiliary surgeons, the upper GI surgeons, and that is represented by in this slide by the group 2, which were 70 patients after the learning experience. The historical group before the learning experience was also 70 patients, and they showed that upper abdominal surgery is increased from 3% to 27%, but more importantly, that the optimal surgical cytoreduction rate improved from together 60% to 91%, which is a great achievement. Although I must say only 27% of these patients had no gross visible tumor at the end. More interestingly, actually, was that the complication rate between the 2 regimens did not improve or did not increase. By more radical surgery, there was not an increased complication rate. There was a longer hospital stay, but also that was not significant in that study. A very important study. Later, they showed the same group that that's 2 years later, in 2006. Okay, that's nice that you can improve the surgical cytoreduction rate, but what does it do to survival? In that study, it showed that by improving the surgical cytoreduction rate, that the survival was also substantially increased, as you can see in the slide on the survival, the Kaplan-Meier there. To put it into perspective, I think I have this slide. Okay, next one. That is what they call maximal surgical effort. The group in London of Christina Fotopoulos also checked that, because it was quite surprising that the morbidity did not really increase by more radical surgery. They did it a little bit different. They took a cohort of patients from one hospital that did less radical surgery and compared that to their own center, which was more radical surgery. And they actually confirmed that there was not a major surgical morbidity increase. They were actually exactly the same. So there is a continuous improvement in surgical cytoreduction, and it showed also in the study of, and there's again a study from the Memorial, it's probably the same data set, and it showed even over the longer term that the no residual tumor advantage on the survival is maintained. So what is that? Upper abdominal surgery and radical surgery. Well, NICE, the National Institute of Health and Clinical Excellence, gave in 2013 a guidance on that. Historically, surgery in ovarian cancer consisted of a hysterectomy with bilateral salpingo oophorectomy, an omentectomy, and a lymphadenectomy. They call it so-called ultra-radical. I think it's a bit of a weird term. I think it's just radical surgery. That was extended, aiming at no Crohn's disease, by stripping the diaphragm, stripping the peritoneum, multiple bowel resections, segmental liver resections, partial gastrectomy, a cholecystectomy, and a splenectomy. But they also mentioned in that guidance that it should only be performed in specialized center, which makes sense because there should be adequate pre-operative, peri-operative, and post-operative management, as well as the availability of HD intensive care units, the availability of a hepatobiliary surgeon, and so on. So all the other specialties should be involved in that. In St. James, we go a little bit further than that. We do mesenteric stripping, not very frequently, but that's what they call a lateral extended endopelvic resection, a Lear composite accentuation, pancreastical resections, and dissections of lymph nodes when they are large of the porta hepatis and the celiac trunk. And this is a bit of, it's not bit, this is unpublished data. It's about 580 patients treated in St. James, and we did actually the same study as the group in the Memorial, with the difference that our aim was no residual disease, whereas in their study the aim was less than 1 centimeter. So historically, we were aiming already for less than 1 centimeter, and that was the baseline years in 2014 and 15. And we recognized that if we want to improve no residual disease, that it probably has an impact on the morbidity of patients. And to counteract that, we took some prerequisites. We boosted our collaborations with the hepatobiliary surgeons, with the colorectal surgeons. We strengthened our enhanced recovery, perioperative care, and we prepared patients better prior to the surgery to optimize them with dietary guidance, exercises, and that's actually part of the enhanced recovery program. And that transition of the surgical approach took place between 2016 and 2017, and we managed to improve with that transition to improve our complete surgical cytoreduction rate, which means no residual tumor, from 57.3% to 74.4%. There was, on the back of that, there were some ramifications to that. There was more, 3 times almost more frequent admission of patients to the high intensive care unit post-operatively. Most of it was electively, just to monitor the patients for the first 48 hours. The hospital stay, and that is the same as in the study of the Memorial, was increased by about 20%, and the operative time was increased by about 50%. So, where do we get now? Where are we at the moment? There was some guidance of the European Society for Gynaecological Oncology, ESGO, and they published the so-called quality indicators for ovarian cancer surgery. There's a scoring system. It's been updated in 2020 by Fotopolo, and the main the 10 quality indicators includes that the surgical site reduction rate should be above, complete surgical site reduction rate, no residual tumors, should be above 65%. About 50% of the patients should be having their surgery up front. I must confess we don't get there in Leeds. We are about like 35% at the moment. The number of cytoreductive surgical procedures per surgeon per year should be around 20 at least. The number of cytoreductive procedures for advanced ovarian cancer should be somewhere between 50 to 100 cases a year. And the other ones are quite open doors. Surgery should be performed by someone who's trained for it. The center should participate in trials. I would recommend every center to participate in trial whenever possible. The treatment should be planned at the multidisciplinary team meeting. There should be an adequate workup. There should be preoperative and intraoperative management, there should be a minimum required of elements in pathological and surgical reports. So, surgical approach for advanced ovarian cancer has changed over the last decades quite tremendously, although not as quick as everyone would have liked. From hysterectomy with bilateral self-pinky oophorectomy to procedures that consist of hysterectomy, bilateral self-pinky oophorectomy, omentectomy, stripping of diaphragm, segmental resections of the liver, pancreastial resections, and so on. So there has been tremendous changes in the surgical approach, and the good thing about it that is always been kept in mind that the morbidity of patients and the burden of the procedure to patients should be as minimal as possible. With the modern technique, we get there. So I quote Winston Churchill on this one. He once said, "To improve is to change, and to be perfect is to change often." Thank you very much.
Thank you so much, Derek, sir, for your valuable presentation.
So, any questions from the participant?
Yes.
Like
If anyone wants to raise any questions, they can proceed with any questions. But till now, in the chat box, none of the persons have raised any queries or inputs. If they want to ask you directly, they can. Or if still you want to move it through the chat box, you can text whatever the inputs that you want to raise.
I see the chat box.
Yes, sir. Yes. Till now, none of the questions have raised, but I'm still checking. Absolutely, probably.
I can't imagine that it was that clear.
That's very clear and informative information they have got without any queries or inputs. That's very presentable, it seems. Thank you so much.
Most welcome. Thank you.
they might have been mesmerized by your presentation. That's why they haven't asked you any questions.
Oh,
So,
maybe you have a question.
Oh, I know. I mean to say that let the participant get time to ask something more, and in the meantime we can move on to the next presentation. But unfortunately, I have to tell Dr. Thomas, who is from the director of Cancer Division from Kerala. He has have an issue with COVID, so that's why he hasn't. He is not joining on this platform today. And it's very sad to say that Professor Human, who met with an accident today, so that's why he's not also been able to attend on this platform today. So we can proceed to the next presentation, and if any questions will be arising, we can take them then in the later part.
I'm on call and I need to go in about 10 minutes. So if there are questions, please don't wait too long.
So any questions for Dr. Bijong? Any question is there, so you can ask. As he said, like he has got an on-call duty, so he might leave in between. So if any questions from the participant?
It is quiet.
It's so quiet. People have understood your presentation.
Really? I mean, there were, of course, there's way more, and there were shortcuts, of course. So I can imagine that there might be questions, but I can maybe elaborate a little bit on that. The study of Maria Vandenberg has been that I consider as a landmark study in the necessity of surgery, has been done as well by Rose and it's also published in the New England Journal. It's a kind of similar study, but there was one difference with that. The patients had their initial open and close procedure performed by a trained gynecological oncologist. So the population was a bit different, but it's well recognized that patients should be having their surgery by a well-trained gynecological oncologist or surgeon to offer them the best prognosis.
So if anybody hasn't got any question, can I ask you one question? Here in India, we do have in ovarian cancer, we do get a lot of stage 3C disease. And if I may say, 80% patient end up with a neoadjuvant chemotherapy and then followed by interval cytoreduction. So what's the scenario at your center?
Well, the scenario in our center was quite similar. Let's say before 2014, a lot of patients had neoadjuvant chemotherapy, and still they have. In all fairness, it was around 20% of the patients had primary surgery versus 80% had neoadjuvant chemotherapy. I think that is most likely on the back of the studies published by Kinu and Ignace Vergote on the non-inferiority trials in neoadjuvant chemotherapy. We try to buff that up a little bit without increasing morbidity to patients, because if on one end you gain something, you don't want to lose it on the other end by having severe morbidity that patients missing their next chemotherapy treatment after that. So in the study we just that I just briefly showed, we were able to increase our primary surgical cytoreduction rate from 20% to 39% in that region. It still is going a little bit up, but you need to monitor that very, very meticulously if it does not have any negative ramifications to it. So in our center at the moment, we are around 39-40% primary versus 60% neoadjuvant chemotherapy. Yeah, some patients have lots of disease, so you need to make a choice. And it is an option. Some patients have less, they're not that fit anymore, so that's another reason to start neoadjuvant chemotherapy. During chemotherapy, a lot of disease will melt away, about 85% response rate. So there is less tumor bulk to be removed in the interval setting. The problem with that is that we are not sure if a complete no residual tumor in the neoadjuvant setting is the same as in the upfront setting. So for young women, we normally tend to move to primary surgery, and for the, let's say, the patients around the age of towards 80, 75 to 80 years of age, they tend to be a lot less fit. And then the choice is more neoadjuvant chemotherapy for those. But it's a moving target. We're still closely monitoring and seeing what every change will have for its ramifications to patients' welfare.
Yeah, that's a nice one. And one more question has been arising. What's your 5-year survival at your center in ovarian cancer stage 3C in epithelial ovarian cancer?
Well, that depends a bit on the subtype of the ovarian cancer. Low grade is different than high grade, clear cell, but overall it's safe to say that about 55% 5-year survival in stage 3C ovarian cancer at the moment, which is, I think it's satisfactory. It could be better. In stage 4, it is a little lower. It's about 35%. And yeah, it is a bit depending on it. So these are overall numbers, but that includes also low grades, which have a better outlook anyway. In high grades only, we are looking at a median overall survival of about 50 months, something like that. So high grade, advanced stage 3. 53% median survival.
Okay. Thank you. Thank you very much.
I think it's comparable to what the most publications out there are at the moment. These are raw numbers. We will publish that in some time.
Thank you, sir. Thank you so much, David Dejong, sir, for your valuable suggestions and inputs. We are really glad to receive the presentation from you. So
Thank you
since
very
I
much.
have checked with the chat box, and any other queries from the organizers can go to the chat box. So I would like to welcome our next speaker. So Dr. Sunil Agarwala, sir, who is a professor and head at Department of Surgical Oncology at IMS and SUM Hospital at Bhubaneswar, Odisha, India. I request Dr. Sunil Agarwala, sir, to move on with the respective presentation.
Thank you.
So,
Yes, sir. Thank you so much, sir.
So thank you.